Hello everyone and welcome to Blood and Hematology YouTube channel. This video is about myelodysplastic neoplasms. Myelodysplastic neoplasms are a closely related group of acquired clonal bone marrow disorders characterized by ineffective and dysplastic hemopoiesis, leading to persistent cytopenias and an increased risk of progression to acute myeloid leukemia. Myelodysplastic neoplasms are rare malignancies with an incidence around 4 to 5 per 100,000. They are primarily a disease of older adults with a median age of diagnosis now approaching 74 to 75 years. Myelodysplastic neoplasms are more common in males than females, and are rare in children and young adults. The risk factors for developing myelodysplastic neoplasms primarily involve aging, prior cancer treatments, and environmental exposures. The risk increases significantly with age. Previous chemotherapy or radiation therapy is a firmly established cause, with approximately 20 to 30% of high-risk cases being therapy-related. Long-term exposure to benzene, petroleum products, and pesticides in the workplace increases the risk. Smoking is recognized as a consistent risk factor for developing myelodysplastic neoplasms. Conditions such as Fanconi anemia, Down syndrome, Bloom syndrome, and familial MDS increase susceptibility. The FAB classification of MDS was based on morphology of the blood and bone marrow supplemented by a cytochemical stain for iron. The fifth edition of the WHO classification has taken the approach of classifying by genetic abnormalities when possible, with remaining cases then classified morphologically. MDS are separated into two major groups in the current WHO classification: genetically defined and morphologically defined MDS. The subgrouping is intended to provide a more accurate classification and thus the basis for targeted therapies. Since the number of dysplastic cell lines is usually dynamic and does not necessarily define a specific MDS type, the distinction between single and multilineage dysplasia is now optional according to WHO. The fifth edition of the WHO classification of the myelodysplastic syndromes neoplasms is shown in the table. MDS diagnostics include cytomorphology, immunophenotyping, chromosome analysis, fluorescence in situ hybridization, and molecular genetics. The diagnosis of MDS is made by the preparation of a blood count, differential blood count, and cytomorphologic examination of bone marrow. In the course of cytomorphological diagnostics, at least 200 bone marrow cells and 20 megakaryocytes should be evaluated. Dysplasia signs should be detectable in at least 10% of the cells in order to be able to call the respective series dysplastic. So-called pseudopelga neutrophils, ring sideroblasts, micromegakaryocytes, and the number of blasts have a special diagnostic significance. Dysplastic hematopoiesis is not confined to MDS, being seen for example during administration of certain drugs, during exposure to various toxic substances, in copper deficiency, HIV infection, and in megaloblastic anemia secondary to vitamin B12 or folic acid deficiency. The diagnosis of MDS requires the recognition of dysplastic abnormalities, with either demonstration of clonality or the exclusion of alternative causes or both. The usefulness of dysplastic abnormalities in MDS diagnosis varies. Some abnormalities, such as an acquired Pelger-Huët anomaly and micromegakaryocytes, are highly characteristic. The granular neutrophils are also highly specific but are present in a smaller proportion of patients. Other abnormalities such as macrocytosis, monocytosis, neutropenia, and cytoplasmic abnormalities in megakaryocytes are less specific and require that alternative diagnoses be excluded. Dysplastic abnormalities in erythropoiesis that may occur in the myelodysplastic syndrome's neoplasms are shown in the table. Peripheral blood smears showing dysplastic abnormalities in erythropoiesis, such as gigantic, binucleated, and bizarre-shaped normoblasts, karyorrhexis, multiple Howell-Jolly bodies, and abnormal nuclear shape. Bone marrow aspirate smears showing dysplastic changes such as multinucleated and binucleated erythroblasts. Dysplastic abnormalities in granulopoiesis that may occur in the MDS are shown in the table. Peripheral blood smears showing dysplastic changes in neutrophils, such as hypersegmentation, presence of macropolycytes, binucleated neutrophils, hypogranulation or agranulation, and neutrophils with ring nucleus and nuclear projections. Peripheral blood smears showing a hypergranular eosinophil with non-lobulated nucleus, a hypergranular basophil, and a binucleated monocyte. Dysplastic thrombopoiesis features that may occur in the MDS are shown in the table. Peripheral blood smears showing platelet dysplasia and numerous platelets, heterogeneous in size, shape, morphology, and granulation. Peripheral blood smears showing circulating micromegakaryocytes. Automated blood cell counters can give diagnostically useful information in patients with MDS. The presence of blast cells can be suspected because of the presence of large peroxidase-negative cells or because of the presence of cells that have nuclei with abnormal light scattering qualities. Red cell histograms and scattergrams may show increased heterogeneity of red cell size and hemoglobinization, macrocytosis, microcytosis, or when there is sideroblastic erythropoiesis, a bimodal distribution of red cell size or hemoglobin concentration. The immature reticulocyte count may be increased even though the absolute reticulocyte count is normal or decreased. Rarely there is an elevated reticulocyte count as a result of delayed reticulocyte maturation. The platelet histogram may show the presence of giant platelets. Platelet function is often abnormal, particularly in higher-grade MDS. Defective platelet function can lead to a bleeding tendency, even in patients with a normal platelet count. Serum ferritin, serum iron, and transferrin saturation may be elevated. Lactate dehydrogenase may be elevated in high-grade MDS. The first MDS patient for presentation is an 84-year-old woman with anemia, increased RDW, and reticulocytosis. Elevated reticulocyte count with increased immature reticulocyte fraction and decreased reticulocyte hemoglobin content indicates an increased but iron-restricted erythropoiesis. Peripheral blood smear examination and leukocyte differential count showed 10% blasts and 1% nucleated red blood cells. Patient's peripheral blood smear showing anisocytosis, microcytes, stomatocytes, macrocytes, and a blast cell. Patient's peripheral blood smear showing blast cells, giant platelets, and a nucleated red blood cell. Dysplastic abnormalities including hypogranulation and abnormal segmentation were observed in patients' neutrophils. Another MDS patient for presentation is an 86-year-old man with anemia, increased RDW, and lymphopenia. Patient's peripheral blood smear showing anisocytosis, hyperchromia, and teardrop cell. Review of the patient's peripheral blood smear showed neutrophils with nuclear projections. A binoculated monocyte and abnormal vacuolation in monocytes were observed in patient's peripheral blood smear. Another MDS patient for presentation is a 92-year-old woman with pancytopenia, anemia, basophilia, and elevated levels of serum iron and transferrin saturation. Patient's peripheral blood smear showed hypogranulation in granulocytes. Another MDS patient for presentation is a 94-year-old man with thrombocytopenia, anemia, and increased RDW. Patient's peripheral blood smear showing thrombocytopenia, anisocytosis, and teardrop cell. Patient's peripheral blood smear showing a granular neutrophils, and an eosinophil with hyperlobated nucleus and some granules with basophilic staining characteristics. The last MDS patient for presentation is an 82-year-old man with thrombocytopenia, anemia, and increased RDW and immature reticulocyte fraction values. Leukocyte differential count showed neutropenia, monocytosis, and 3% nucleated red blood cells. Patient's peripheral blood smear showing thrombocytopenia, anisocytosis, and teardrop cells. Patient's peripheral blood smear examination showed neutrophils with nuclear projections and abnormal segmentation, normoblasts with irregular outlines, and a binoculated monocyte. Immunophenotyping in myelodysplastic neoplasms is an important diagnostic and prognostic tool that uses flow cytometry to detect abnormal antigen expression patterns in bone marrow and peripheral blood cells. It helps distinguish myelodysplastic neoplasms from reactive cytopenias and other hematologic disorders, and identify lineage, maturation stage, abnormal antigen expression, and blast percentage. Cytogenetics is of central importance in myelodysplastic neoplasms diagnostics, and also allows an assessment of prognosis in patients with cytomorphologically confirmed MDS. Recurrent chromosomal aberrations in myelodysplastic neoplasms are listed below. Fluorescent in situ hybridization is used to detect defined genetic aberrations. This method can be used in myelodysplastic neoplasms to screen for the most common genetic alterations when chromosome analysis could not be successfully performed. Furthermore, results from classical chromosome analysis can be confirmed by FISH. FISH also allows quantification of the aberrant clone on native material and thus serves as a progression marker. Molecular genetics plays a central role in the diagnosis, classification, prognosis, and therapeutic decisions in myelodysplastic neoplasms. With next-generation sequencing, recurrent somatic mutations are identified in about 80 to 90% of patients. Major categories of mutations in myelodysplastic neoplasms include RNA splicing, DNA methylation, chromatin modification, transcription factors, signal transduction, and DNA damage response. Myelodysplastic neoplasms must be differentiated from several conditions that cause cytopenias, dysplasia, or bone marrow abnormalities. Accurate diagnosis requires integration of morphology, cytogenetics, molecular studies, and clinical findings, as emphasized in the WHO classification. Key differential diagnoses and diagnostic procedures are listed in the table. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.